Good afternoon, everyone. We'll begin in just a few minutes. Good afternoon, Dr. Frere. I'm going to go ahead and get started if that's okay with you.
That'd be perfect.
Wonderful. Good afternoon, everyone. Thank you so much for joining the Los Angeles County Department of Public Health today, February 24th, for a media briefing. Today we have Director of Public Health, Dr. Barbara Ferrer, presenting. Dr. Ferrer will then take your questions. As a reminder, to ask a question, please use your hand icon, or you may chat me, the host. Dr. Ferrer, when you're ready.
Oh yeah, thank you so much. And good afternoon and welcome to today's briefing, where I'll share our latest COVID status update and respond to questions. In today's briefing, I'll share our current metrics on cases, hospitalizations, and deaths, including data showing the impact of poverty on these outcomes. I'll also share our latest information regarding the variants that are circulating in LA County. I'll present updated vaccination coverage data and share our schools update and provide information regarding masking requirements, discuss the interim indoor masking policy, and make note of the state's planned review of school mitigation strategies. I will finish off with remarks on our progress towards moderate transmission and briefly touch on the state's updated COVID-19 framework and expected changes to the CDC framework. With that, we can go ahead to the first slide. Since we announced that we're reaching the end of our devastating winter surge, our situation has continued to improve with sustained declines in many of our metrics. While some work is still needed to further reduce risk in places where we work and gather, our collective efforts to vaccinate, boost, mask, and follow other safety measures are bringing us closer to pre-surge levels. As we move forward and continue to see improvements associated with less transmission, we will implement sensible changes to our mitigation strategies that allow us to use the most appropriate tools for protecting residents and workers from the damaging effects of COVID. Before we start with a look at our customary metrics, I do want to note that starting this Sunday, February 27th, we're no longer going to be reporting COVID metrics on Sundays. When we report on Monday, we'll note the Sunday metrics separately from the Monday metrics. Over the last week, cases and test positivity rates have once again declined. Today, we're reporting slightly under 2,000 new cases. The average number of daily new cases reported over the last 7 days has declined to about 2,400 from about 3,800 cases for the previous 7 days. And while we still have what's considered a high rate of community transmission, our 7-day average of daily cases has declined to 24 new cases per 100,000 residents. And our 7-day average daily test positivity rate has also declined to 2.2%, which means that 1 out of about every 50 test results reported to us were positive. This is compared to about 1 out of every 4 near the beginning of the year during the winter surge. In addition, our hospitalizations have continued their decline, and today we're reporting 33% fewer hospitalizations than last Thursday, with 1,150 people currently hospitalized with COVID-19. While deaths remained elevated over the past several weeks, there have been slight drops in the average number of daily deaths reported. For the past 7 days, there were an average of 54 daily deaths reported. That's versus an average of 67 reported over the prior 7 days. I know the tragic toll that each COVID-19 death has, and I send my wishes for comfort and healing to everyone who has lost a colleague, friend, or family member to COVID-19. We can go on to the next slide. This slide is a trend line. Somehow you lost the slide deck. Okay, can we go to the next slide? Great. This slide is the trend line showing average cases, hospitalizations, and deaths from July 1st, 2020 through today. It shows the drastic increases in Omicron cases during the winter surge, as well as the steep declines that we've seen over the past several weeks. Though our 7-day average for daily cases, shown by the green line, has not yet dropped to pre-surge levels, it has declined by 94% from the high of an average of over 40,000 cases on January 15th. Hospitalizations, shown in yellow, and deaths, shown in blue, also increased sharply during the winter surge, but not as quickly, likely due to the impact of vaccines, which are highly effective in preventing severe illness and death, as well as some availability of effective therapeutics. The 7-day average of new hospital admissions is down to 140 as of yesterday. As we continue to slow community transmission and improve access to effective therapeutics, I hope that we'll see further declines in our deaths. Next slide. These graphs show 7-day daily averages for cases, percent positivity, and hospitalizations prior to the surge, at the peak of the surge, and currently. As you can see, we've made excellent progress over the last several weeks in slowing transmission and preventing hospitalizations. In fact, we're now moving close to pre-surge levels. As we experience the relief associated with this progress, we'll need to remain aware of the factors that could impede our ability to reach lower levels of risk, including the slowing pace of vaccination and the chance for a new variant to emerge that evades vaccine protections. Given the continued unpredictability of the virus, we're going to need to always remain prepared and able to tailor response actions as appropriate. Next slide. We do continue to closely follow developments regarding the Omicron BA.2 variant, including any findings related to whether, when compared to BA.1, it may spread more easily from person to person, lead to more severe illness, or be more resistant to treatments or vaccines. The World Health Organization recently noted the following findings. Initial findings still suggest that BA.2 appears to be 30% more transmissible than BA.1, which is the most common Omicron subvariant. Although reinfection with BA.2 following infection with BA.1 has been documented, initial data suggests that this is relatively rare, and infection with BA.1 provides strong protection against reinfection with BA.2, at least for the limited period for which we have data available. Real-world data from South Africa, the United Kingdom, and Denmark did not show a difference in severity between BA.2 and BA.1. These findings are in contrast to some data from Japan that showed higher severity, but most of that was in animal models. We do continue to monitor for variants that are circulating in LA County, and this slide shows our latest sequenced variants. The Omicron variant remains our predominant variant in red, accounting for 100% of all cases with sequenced specimens collected in the week ending February 12th. The BA.1.1 lineage, a descendant lineage of BA.1, was the primary Omicron subvariant identified. BA.2 has been increasing slowly, but still makes up a very small proportion of all sequenced cases. As of February 12th, BA.2 accounted for only 67, or 1.2%, of sequenced Omicron cases identified in LA County over the past several weeks. This is consistent with findings that while BA.2 has become the predominant variant in some countries, it is not rapidly spreading in the United States. Next slide. Throughout the pandemic, we've seen that COVID-19 has disproportionately impacted certain communities and groups in LA County, including communities of color, communities with large numbers of essential workers, and under-resourced communities. Today, we're sharing data that shows the interplay between poverty and COVID-19 outcomes. The next 3 slides will show the 7-day adjusted case rates, hospitalization rates, and death rates for individuals 5 and older by vaccination status and area of poverty. As you can see, differences in COVID-19 cases, hospitalizations, and deaths are associated not only with one's vaccination status, but also with whether a person lives in an area with higher or lower rates of poverty. And persons living in areas with more poverty are at substantially higher risk. While this pattern was more pronounced for unvaccinated individuals, there were also alarming disparities amongst people who were vaccinated. Thus, although vaccines are highly protective, being vaccinated alone did not eliminate the inequitable outcomes for residents living in high poverty areas. In communities where 30% or more of the people are living in poverty, the case rate for unvaccinated individuals was nearly 9 times the case rate for unvaccinated individuals living in wealthy communities where less than 10% of people are living in poverty. Case rates for both vaccinated and boosted individuals were also substantially higher in communities with the greatest poverty than compared to communities with the least poverty. In fact, unvaccinated people living in wealthy communities had a similar rate of infection when compared to fully vaccinated and boosted residents living in high poverty communities. Next slide. This slide shows age-adjusted hospitalization rates by vaccination status and area of poverty for people 5 years of age and older for February 5th through February 11th. Regardless of vaccination status, living in an area with high poverty was associated with substantially higher risk for hospitalizations. And in this instance, the higher the level of poverty, the larger the disparity. For example, fully vaccinated and boosted individuals living in communities with the highest rate of poverty were almost 3 times more likely to be hospitalized than those living in communities with the lowest rates of poverty. Furthermore, as you can see, unvaccinated people living in the wealthiest communities were less likely to be hospitalized than fully vaccinated people who were living in communities with high poverty. Next slide. Finally, this slide shows age-adjusted death rates by vaccination status and area of poverty for people 5 years of age and older from January 29th to February 4th. Again, regardless of vaccination status, persons living in areas with more poverty were at substantially higher risk, in this case, for dying from COVID. As was the case for hospitalizations, the higher the level of poverty, the larger the gaps that we're seeing. For instance, among unvaccinated individuals, the age-adjusted death rate steadily increased as poverty levels increased. The age-adjusted death rate was 8 deaths per 100,000 residents in our wealthiest communities, climbing steadily in communities with increasing levels of poverty, and jumped to a disturbing rate of 76 deaths per 100,000 residents in communities where 30% or more of residents are living in poverty. Shockingly, those fully vaccinated and those vaccinated and boosted living in communities with the highest rates of poverty were 3 times more likely to die from COVID than those living in the wealthiest communities. And underscoring the stark disparities between wealthier communities and communities with high rates of poverty, we see here that an unvaccinated person living in the wealthiest communities had less risk of dying due to COVID-19 than a fully vaccinated person living in communities with the highest levels of poverty. These data on cases, hospitalizations, and deaths are alarming, as they show the significant impact that poverty can have on COVID-19 outcomes. Inequities were most pronounced for those who are unvaccinated, but also significantly affected vaccinated and boosted individuals. So despite the strong protection that vaccines afford, getting vaccinated alone was not an equalizer for people living in areas with high rates of poverty. Where people live and work clearly has a tremendous impact on their risks for exposure and the availability of health-affirming resources. We need to remain committed to resolving the complex and long-standing issues accounting for these distressing inequities, and immediately ensure that our post-surge actions do not widen the gaps by failing to provide additional resources and protections to those at highest risk for COVID-19 transmission, hospitalization, and death. Next slide. While definitely not perfect and not an equalizer, as we just saw, vaccines do remain one of the most powerful tools that we have against COVID-19. And given their importance, I'm once again reporting out on our vaccination rates. Since the start of the year, we've made incremental progress in getting our LA County residents vaccinated. Between January 6th and February 20th, the percentage of residents 5 and older who were fully vaccinated increased from 71% to 74%. And the percentage of residents 12 and older who are fully vaccinated increased from 77% to 79%. However, our pace of vaccination has slowed significantly. And while this is to be expected, given the 8 million county residents have already been vaccinated, there are still approximately 1.7 million eligible residents who haven't yet received their first dose of COVID-19 vaccine, as well as roughly about 2.7 million residents who are eligible for but haven't received an additional or booster dose. Vaccination coverage for children 5 to 11 years of age remains low, with only 28% of children in this age range fully vaccinated as of February 20th. We know that our vaccination rates, these lower vaccination rates, are leaving 5 to 11-year-old children and our communities at risk, since these children can become ill as well as unknowingly infect family members, friends, students, teachers, and others. To stay on our path towards lower transmission and prevent the emergence of a variant of concern, we do need to get substantially more of our residents vaccinated and boosted. Next slide. And to increase vaccination coverage, we're going to need to acknowledge and align resources to address the disparities in vaccination coverage that contribute to the disparate COVID-19 health outcomes that we're often talking about. This includes disparities that are based on one's place of residence or race and ethnicity, as seen on these next two slides, detailing coverage rates among children 5 to 11 years of age in LA County. Each map shows vaccination coverage for one or more doses of COVID-19 vaccine for children 5 to 11 for each of our health districts for a different racial and ethnic group. Yellow shading denotes health districts with vaccination coverage that's under 22%. Green denotes coverage from 22 to 31%. Blue denotes coverage from 32 to 54%. And purple shading denotes vaccination coverage that is greater than 54%. The first map, or like on my left, shows coverage levels for Asian children between 5 and 11 years of age. Because this group had the highest vaccination coverage, it serves as a comparison group on these slides. The other maps show vaccination coverage by health district here on this slide for Black and African American children and Latinx children. On the next slide, we'll look at the distribution for vaccination coverage for white children. As you can see from these three maps, efforts are needed to improve coverage for 5 to 11-year-olds for all racial and ethnic groups, but particularly for Black, African American, and Latinx children. Vaccination rates for these groups are low across the county, particularly in the health districts located in the areas of South LA, South Central LA, East LA, parts of the San Gabriel and San Fernando valleys, and all of Antelope Valley. Next slide. This slide shows the vaccination coverage levels for white children ages 5 to 11 by health district again, compared to the rates for Asian children, shown again on the first map to my left. You can see that in many districts, vaccination rates for white children were lower than the rates for Asian children, but they are higher than the rates for Black and Latinx children. Rates for white children were highest in some of the health districts in South and Southeast LA, and lowest in the Antelope Valley. As mentioned, these maps show the gaps in vaccinations based on race, ethnicity, and geography. Overall, as of February 20th, 58% of Asian children between the ages of 5 and 11 received at least one dose of the COVID-19 vaccine. That's versus 40% of white children, 21% of Latinx children, and 20% of Black children in this age range. These disparities continue to point to the need to address policies and practices that marginalize the concerns of individuals, which can contribute to hesitation and trusting in these vaccines. We're working with our partners to build confidence in vaccines and increase uptake in under-vaccinated communities. Vaccines are available at no charge at over 1,500 sites and through mobile teams throughout the county, including in areas with the lowest coverage. We're also working with trusted partners to increase awareness, answer questions, and link individuals to vaccination sites in hard-hit communities. Strategies include door-to-door outreach in the areas surrounding our vaccination clinics, tabling at vaccine clinics, schools, and community events with folks that are prepared to answer questions, conducting outreach to parents at schools, offering school-based vaccine clinics, providing information and vaccine reminders through phone calls and text messaging, and having our social media messages feature local residents. We're also obviously working with pediatricians, family medicine docs, and clinical providers so that they can also feel well prepared to be able to answer questions and help those that are ready get their vaccination appointments. Next slide. Schools do remain vital partners in our efforts to prevent and control COVID-19, and routine and response testing are still significant elements of our school-based strategy. Testing volume in recent weeks has declined slightly because LAUSD and other school districts are appropriately excluding students from testing, routine testing, who recently tested positive for COVID-19. Recent data shows that between February 14th and the 18th, nearly 460,000 tests were administered, with a test positivity rate that's now dropped to 0.8%. That's down from about 14% at the beginning of the year. This steep decline likely reflects both the lower rates of community transmission, as well as the impact of the mitigation strategies that are in place at schools to protect students, teachers, and staff. Go to the next slide. This slide shows the number of COVID-19 cases among students and staff in TK through grade 12 schools from the beginning of this school year through February 20th by grade level. As you can see, throughout most of the school year, student and staff cases remained very low, but then they increased rapidly starting in late 2021 and early 2022 and have substantially declined dramatically in recent weeks. During and post-surge, the largest number of cases have been among elementary school students, also the lowest number of students that are vaccinated, and that's shown with the solid yellow line, followed by high school students, shown by the solid blue line, and then middle school students, shown by the solid green line. Youth sports is shown by the solid red line, and it's accounted for the fewest number of student cases. In each of these settings, student cases are declining fast. Our latest data show that in just 1 week, cases declined by 65% among elementary school students, 61% for middle school students, and 64% for high school students. There are fewer COVID-19 cases among staff than among students. There are also a lot less staff than there are students, as shown by the dotted lines. Staff cases have also been declining, and counts are now similar to the counts that we saw prior to the winter surge among staff. Of note, as was the case for students, the largest number of staff cases were at elementary schools, then high schools, then middle schools, and finally staff working with youth sports. Next slide. Public Health is currently investigating 38 active school outbreaks. This is down from 46 that were under investigation last week and 56 the week before that. This week's outbreaks include 13 new outbreaks that were opened between February 13th and February 19th, 7 in elementary schools, 3 in middle schools, and 3 in youth sports. When combined with the low positivity rate at schools and declining cases among students and staff at over 3,100 schools across the county, the relatively low number of outbreaks suggests that school-based strategies, including the screening and response testing, isolation and quarantine, infection control guidelines, and masking, continue to help keep transmission at schools low. This in turn helps to keep our students, teachers, and staff safe, and most importantly, in the classroom. Next slide. On this slide, we just wanted to show you the 77 outbreaks that have happened in TK through grade 12 schools and programs that were open from January 1st through February 19th. As you can see, the majority of outbreaks were in elementary schools. Those are the yellow dots, followed by youth sports, and outbreaks occurred all across the entire county. Next slide. I'll go to the next slide, great. Given the concerns raised by some parents about masking in schools and the need to balance risks and benefits, I wanted to share information that has been used by the CDC, the state, and us in assessing safety protections needed at schools, while also acknowledging that many staff, teachers, and parents still do support masking at schools. A study from Johns Hopkins University of 2.1 million individuals last year showed a 38% increased risk of COVID-related illness in households where a child attends in-person school. However, as layers of school-based safety measures increased to 7 or more measures, including student masking, the increased risk went away completely. This suggests that masking requirements, together with multiple layers of school-based protections, can help keep families, unvaccinated siblings, and high-risk family members safe from COVID transmission while their children are attending schools. Another study from researchers at Duke University analyzed data from more than 1 million K-12 students and staff members in North Carolina over nearly a year of masking requirements from August 2020 through July 2021. They found that in-school transmission over the fall, winter, and summer months remained as low as 1%, even when rates in communities were surging. Masking in schools was identified as a unifying theme across all these time periods that helped keep the spread in schools very low and students safe. A CDC study of Arizona schools between October of 2021 showed that COVID-19 outbreaks were much more common in schools without masking requirements as compared to schools with masking requirements. And as we showed last week, and the state showed as well, data indicates that in states that have masking requirements, there's less disruption to student learning. It's also, as I mentioned earlier, there remains solid support amongst parents for masking in school settings. According to a new public survey from CBS News YouGov, the majority, or 57% of parents of school-age children, support masking requirements in schools, compared to 36% who stated that masking should be optional and 7% who said that masking should not be allowed. Similarly, in a poll conducted by UC Berkeley, which was co-sponsored by the LA Times, 61% of parents in California supported the continuation of wearing masks in school for the remainder of the school year. At this time, the state continues to require indoor masking for individuals at school sites, regardless of vaccination status, as part of a comprehensive school safety program. The state is reassessing mitigation strategies and plans to announce considerations and timeframes on February 28th. The state will provide us with a framework for mitigating spread in schools that we will likely align with, noting that as recommended by the state, we'll also consider our county metrics in finalizing the county's plan. Next slide. We were able to remain open during the damaging winter surge because we used an extensive set of protective measures that helped diminish the impact of Omicron. While we're relieved to have significantly reduced the stress on our healthcare system, leading to the changes that have been introduced this week in the county's health officer orders, there does remain work to be done to close gaps, as we just noted today, in outcomes by geography and race and ethnicity, since this disproportionality continues to cause sizable disruptions, illness, and death for many across the county. So in moving forward during post-surge, there are still settings and situations where it will remain appropriate to use the powerful tools at hand that impede virus transmission. Let me just quickly review the modifications to our health officer order that allow establishments, businesses, and venues verifying vaccination and negative test status to offer optional masking for fully vaccinated individuals beginning tomorrow. Establishments, businesses, or venues have two options for removing masking requirements for fully vaccinated individuals. Option number one, which again starts on Friday, is for establishments, businesses, or venues that want to allow fully vaccinated customers and workers to unmask indoors. At these settings, the establishments must verify that 100% of customers 5 and older and workers prior to or upon entry to an indoor space provide proof of full vaccination against COVID-19, or if not fully vaccinated, provide proof of a recent negative COVID-19 viral test result. Tests for customers must be taken within 2 days of entry if it's a PCR test, or 1 day if it's an antigen test. Employees will be allowed to submit a negative test result every 3 days. Those who are not fully vaccinated or don't show proof of vaccination are required to provide this negative test. And they also are required, per state regulation, to continue wearing a well-fitting mask while indoors, except when they're actively eating or drinking. There's a second option, which starting this Friday, establishments, businesses, or venues that want to allow their fully vaccinated customers to unmask indoors, while all on-site workers remain masked, must verify that 100% of customers 5 and older prior to or upon entry to indoor spaces provide proof of full vaccination against COVID-19 or provide proof of a recent negative COVID-19 viral test result. Tests for customers, again, must have been taken within 2 days of entry for a PCR test and 1 day if it's an antigen test. As a reminder, fully vaccinated customers may be unmasked in the indoor setting, while customers that are not fully vaccinated must continue to wear a well-fitting mask while indoors as required by the state, except when they're actively eating or drinking. There are several important features to these changes. Businesses and other establishments are not required to implement these options. If they prefer, they can continue to require indoor masking for all customers and employees. Given that we're likely to be only a short bit away from lifting indoor masking requirements across the county, given our rapidly declining case rates, those establishments that have not yet established systems for verifying vaccinations or negative tests may want to delay building out any expensive verification systems and instead continue the indoor masking requirements until the county lifts these requirements without the need for the verifications. As we've noted in the past, these changes to the health officer order do not apply in settings where state or federal rules require masks to be worn indoors, regardless of vaccination. This includes schools, childcare facilities, youth settings, healthcare settings, correctional facilities, homeless and emergency shelters, cooling centers, when riding public transit and in transportation hubs. We also continue to recommend masking when indoors, especially for those who are particularly vulnerable to COVID-19 illness and those who live with people who are vulnerable. Masks provide strong protection to the person wearing them as well as to the people around them, and are one of the easiest things we can do to prevent COVID-19 spread. This means that even in sites requiring vaccination and testing verification, any individual showing proof of full vaccination prior to entering can still choose to wear a mask indoors. To ensure that workers have enough protection at their job sites, we have upgraded the requirement for employers who are choosing either option 1 or option 2 to provide masks to provide their employees upon request with masks, and that the offering must now include a respirator mask, an N95, a KN95, or an N94 mask. This is for voluntary use by employers during work, and they need to be provided at no cost to the employee. We've posted a detailed toolkit on our website at www.ph.lacounty.gov. It has a lot of information on how to be in compliance with this modified health officer order, and we encourage businesses and workers to take a look and contact us with their questions. Next slide. As noted, masking is going to be required in indoor settings until we're at or below moderate transmission for 7 consecutive days, except where required by state or federal regulations to keep those masks on, or at the establishments that adhere to the new interim indoor masking policy. Our current masking policy aligns with the current CDC guidance, which recommends indoor masking in areas of substantial and high transmission. We do anticipate a change to the CDC guidance soon, at which point we'll consider how to adjust our requirements. In the interim, reaching the milestone of moderate transmission will automatically trigger the change to the masking requirement. And this slide shows our progress toward that milestone. The observed 7-day cumulative case rate over the past week is shown in the green, in that green line. And the projection for the 7-day cumulative case rate is shown by the blue dashed line. The projection is based now on a rate of decline of 5.5%, which is the rate of decline between February 16th and the 23rd. We know that diseases don't follow a linear rate of decline and that our rate of decline may not be consistent over time. So this is just an estimate. The orange line shows the threshold of 50 cases per 100,000 residents, which translates to a 7-day average of about 730 cases per day. Moderate transmission is defined when our 7-day cumulative case rate falls below this threshold. Based on the current rate of decline, and as you can see here, we do anticipate reaching moderate transmission in mid-March. The best chance that we have for reaching this on schedule is for each of us to continue to do our best to adhere to recommended safety measures, including the masking, testing, and vaccinations. Next slide. Throughout the pandemic, when we've been developing our mitigation strategies, we've been lucky to be able to consider science-based guidance issued by the CDC and the state. The federal and state frameworks make room for the need to also consider local conditions before finalizing action plans in each local jurisdiction. As early as tomorrow, we expect the CDC to release an updated framework for managing COVID-19, which of course we'll carefully review to assess opportunities for alignment. Although CDC hasn't yet released the plan, there is some information regarding key elements of the updated framework that have been shared. Based on this information, we anticipate that the framework may focus on the following 3 goals: prevent severe disease, minimize the burden on the healthcare system, and protect the most vulnerable. These should resonate since they've really been guiding lights for all of us for many, many months now. We also anticipate that the framework will include updated metrics that support the overarching goals and can be used to monitor progress and help guide local strategies, policies, and decisions. For instance, the metrics are likely to be related to vaccination coverage, community indicators as will be defined by the CDC, and local metrics, including information about circulating variants of concern, outcomes in high-risk congregate settings, or results from wastewater surveillance. We also expect that the framework will provide recommendations to local health jurisdictions and partners for community actions and interventions, with, again, a potential focus on vaccination activities and prevention measures, including individual prevention behaviors and community strategies. When this framework is released by CDC, we'll carefully review the proposed goals, the metrics, and the strategies in relation to local conditions and priorities, determine how to best align and integrate relevant metrics and strategies in our own mitigation plans. In addition to the anticipated CDC changes, the state has also released an updated framework titled the California Smarter Plan, the next phase of California's COVID-19 response. This plan moves the focus to preparedness for the next phase of COVID-19, which may include future surges and new variants. The core components are shots, masks, awareness, readiness, testing, education, and RX, which refers to access to treatments. We are proponents of the emphasis in this plan to apply the lessons learned after 2 years of living through the pandemic to future efforts and the need to be prepared for the opportunities and challenges that could lie ahead. We're grateful for all the efforts so many have made to protect each other, and we're eager to prepare for the post-surge future. We will continue to use the state and federal guidance along with local conditions to inform the county's plan for minimizing illness and disease and protecting those most vulnerable. Thank you, and we're now open for questions.
Thank you so much, Dr. Freer. As a reminder, if you have a question, you can chat me, the host, or you can raise your hand using the hand icon. Our first question is going to come from Marla Tejas from Fox 11. Marla, go ahead.
This is a first for me. Wow. Thank you so much for taking my question first and foremost. Dr. Ferrer, as always. Okay, just a few minutes ago, just as you did last week, you laid out the metrics to lift the indoor mask mandate in its entirety. You projected meeting that metric, which is that much lower case rate, in mid-March. You've made it abundantly clear that the goal is moderate transmission, defined as an average of 730 new daily cases. LA County has not met that metric. You have decided to lift the mandate for the vaccinated, which is about 80% of county residents 12 and older. So why the change now for just vaccinated when we know vaccinated people can still get COVID and spread it, and we are still in this high transmission period? Also, how much did political and public pressure play into your decision, especially considering LA County Supervisor Janice Hahn tweeted out your decision ahead of your own announcement just a couple of days ago? Lastly, how does enforcement work for businesses? Are there consequences for these business owners for not enforcing the new guidance? And if so, what are those consequences? Thank you so much.
Yeah, thanks so much, Marla, for the questions. And I just want to clarify on what the change is, because different from just lifting the masking requirement, which is what we plan to do, very soon when we get to lower transmission. This allows, in places where you're verifying that people are either fully vaccinated or they have that negative test result, that then it's a safer environment where those who are fully vaccinated can go ahead and lift their masks, while those who are not, even if they've had a negative test result, will need to keep their masks on. That's to stay aligned with the state order. And again, I want to note that we have situations already that have been pointed out to us, and I thank the businesses that have really come forward to explain to us their dilemma, where there are settings where people have been removing their masks in situations where there's vaccination verification and or verification of a negative test result. Those are at the mega events where people are eating or drinking, and they're also at our bars, lounges, nightclubs, wineries, distilleries, breweries, where when you go inside, pretty much nobody is wearing a mask. But that's because they've created this additional layer of safety by doing the verifications. So it was pointed out to us that, particularly there are other places in LA City where they're doing verifications already. Could we allow them that same ability, given that they've created a safer environment and that they've verified that the environment is safer, to go ahead and lift the masks? And I know, people are asking us, why the change? I think we've always tried to listen to the folks we're in service of about being sensible with the measures that we ask folks to adhere to. And we know that, as the state has said, as CDC has said, that masks provide a lot of protections. We also know that there are some settings where there are other layers of protection that are already introduced that also provide a fair amount of protection. And while I do appreciate, sort of the note there that people who are fully vaccinated can still go ahead and get infected, I want to continue to point out that they get infected at a lower rate than unvaccinated people, and that most importantly, very few of them end up hospitalized, and even smaller numbers of them will end up passing away from COVID because of the protections of the vaccines. So we do think that additional layer, given that we're on this sort of post-surge journey now, helps us, again, ease into removing masks in places where we've added a layer of protection. And once transmission gets lower, we feel pretty comfortable that we can lift the requirements, moving, of course, to strong recommendations. I know there are many people that are going to always feel safer while we have this virus circulating to keep a mask on when they're in indoor situations that with lots of people they don't know, and when they're in outdoor crowded situations. And we think that's sensible. There's nobody that's not recommending that people keep masks on to protect themselves and to protect others around them. It's just a question of what's required and what's recommended. In terms of, sort of, what part does politics play? I think for us at public health, it's a lot less about politics than it's about listening to constituents and being reasonable as we chart a path forward. So, I wouldn't, I don't call that politics. I call that involving lots of different people and helping you understand how they're experiencing this pandemic, and trying to exchange information about what we see and what they see, what we feel, what they feel, and then come to hopefully a place where people can feel pretty confident in what we're doing. And I recognize that, the last few weeks, it's been challenging for everyone. It's always challenging when either goalposts change or conditions change, to be flexible enough to figure out how to best move us forward. And, I hope that, everyone does feel somewhat reassured that we both listen and adapt, but we also always look at the science and we always look at the obligation to minimize illness and disease and protect those who are most vulnerable. And in terms of compliance, this follows all of our health officer orders. Our inspectors will be out, starting Friday evening. We spend the first few days always educating folks. So we anticipate that, we'll need to provide a lot of information and technical assistance. And we have great inspectors who are prepared to do that. We almost never issue any citations for violations of new health officer orders in the first few days, unless they're, sort of flagrant health and safety concerns, often unrelated to our health officer orders, or this specific health officer order, and maybe more related to other requirements at some of these venues. But it's education, it's being available, it's providing technical assistance. But you're absolutely right, Marla, that at some point, if we're on our third visit and we're not seeing progress, or there's just blatant defiance, we do move ahead with the citations. So thanks for that. We'll take the next question.
Our next question comes from Christy Hutchings from LA Daily News. Christy, go ahead.
Hello, Dr. Ferrer. Thanks so much for taking our questions. I have a little bit of a two-parter here for you. So first of all, could you expand a little bit on why those individuals living in communities with higher poverty have worse COVID-19 outcomes? Is it a lack of access to healthcare, greater exposure to the virus, or something along those lines? And then along with that, how does the county intend on addressing those health inequities and closing that gap, as you mentioned in your presentation earlier today? Thank you.
Yeah, thanks so much, Christy. And I appreciate the focus on this. Obviously, it's deeply troubling. So yeah, I think it's a complex set of issues that contribute to the disparities, and oftentimes, because it is complex, people don't really want to talk about it, but I think we need to. It's really clear that where you live and where you work has an impact on your health status, and it's no different for COVID than it is for a host of other illnesses that we track. And there's a couple of reasons for that. One is where you live and work has something to do with what we call health affirming resources are available. And some of that you've all seen play out. You've seen it play out when we talk about exposures to environmental hazards, much more likely in lower income communities than in wealthier communities, to go unabated for longer periods of time. You've seen it when we've talked about food deserts, the inability to be able to access affordable, healthy foods. You've seen it when we've talked about the inability for some people to have access to places where they can safely exercise. You've seen it in people's access to healthcare services. I think we hear a lot from the leadership over at the MLK Hospital about what their experiences has been the past 2.5 years with COVID. And we compare that to hospitals in other communities that haven't really either seen or experienced this pandemic the same way. So I think we just have to be mindful that, certainly where you live has a tremendous impact on what's available to help you be as healthy as possible. I think where you work also has an impact, and this has certainly become clear with COVID. People whose job offers them many more opportunities for exposures have had many more exposures, and essential workers from the very beginning have borne the brunt of a lot of the high case rates, which then translate, of course, into higher hospitalizations and higher death rates. And that's been consistent. And we have worked hard to address sort of the immediate issues in front of us around access to vaccines, access to therapeutics now, access to testing. But it's not sufficient, because we also need to address these larger context issues. What I hoped was clear today is vaccines provide awesome protection, but it's not an equalizer. And it's not enough to just have good access to vaccines, because as we saw, being vaccinated, if you're a person living in a community with high rates of poverty, doesn't afford you the same protections that it affords people living in wealthier communities who are vaccinated. And most troubling was that the people in the wealthiest communities who are unvaccinated actually do better than the people who are fully vaccinated and boosted, living in communities with high rates of poverty. And that reminds us that the work isn't simple in front of us. We have to address some of the long-term issues that contribute to why people who have less resources are doing worse. One thing we know, just looking at data around other health illnesses and then looking at what we see around COVID outcomes, is that if you have underlying health conditions, and particularly issues related to diabetes or asthma, you're at higher risk of having a bad outcome should you get infected. And we already know that there's a lot of disproportionality throughout LA County and who is more likely to have some underlying health conditions. Not because their behaviors are very different from other people's behaviors, but because their access to resources looks very different. So again, that contributes to what we're seeing around hospitalizations and death data. But it reminds us that it's not enough to just work on ensuring access. We have to address these larger issues about making sure that we are always attentive to the need for additional resources and protections in those communities that are hit the hardest. So thanks for that, Christy. Move on to the next question.
Our next question comes from Ron Lynn at the LA Times. Ron, go ahead.
Hi, Dr. Ferrer. Thanks so much for taking our questions. Really appreciate it. A quick question at the top. In that early bar chart colored green, blue, and orange, there was a graph that said 7-day average daily hospital admissions. I'm guessing that refers to new daily COVID hospital admissions for that date and not the total COVID hospital census for that date. Okay, great. And then our real questions are today, CDC masking guidance, the K through 12 indoor mask mandate, and that poll that you mentioned. So first, once CDC revises its mask guidelines, how soon do you think you'd adjust the threshold for lifting the indoor mask mandate? If the CDC changes its criteria tomorrow morning, would you release your metrics tomorrow night, or is that more of like a next week thing? Second, you've made statements, including today, suggesting the indoor mask mandate in K through 12 classrooms has been important in keeping schools open. I think you said today that you think you'll likely align with the state's framework as it relates to loosening K through 12 mask rules while taking into account local metrics. Can you clarify? You made a pretty big case for why masks are important in K through 12 schools. How is that consistent with aligning with the state and lifting the mask requirement? And then finally, you referenced that UC Berkeley LA Times poll that found that nearly 2/3 of California voters support mask and vaccine mandates in K through 12 schools. This poll also found that a large majority of white parents are confident that their children are safe from the coronavirus at school, while Latino parents were most worried that their children were not safe. Given the pitch to public debate about this, what do you think of those results? Thanks.
Yeah, thanks so much. And maybe I'll start with the last one, just because I didn't write it down. Yeah, I think that, again, I appreciate everybody who worked on that poll, because it's real-time data for us, and it's important to, again, understand what different people in our communities are feeling. I think, if your experience in this pandemic has really included losing family members, losing friends, to the virus, if you've experienced some severe illness yourself, or you've been in families where it's really spread a lot, you know how easy people can go from being healthy to not being healthy, and how tragically in some communities they've lost a lot of their families, a lot of their friends. And I think it's out of that experience that people then, go through the rest of their world figuring out how to stay safe. And if you've experienced the worst of COVID, you know that risk is real, and it's not elusive, and it can in fact devastate the family. And I think that is a source of a lot of worry. You've seen, the Latinx community, the Black community, they've had much higher rates of bad outcomes associated with COVID, and they've had real experiences, I think, shape the way they view what we need to do. So I'm not surprised that they want to make sure that schools are very safe places. They also, as I noted earlier, tend to experience higher rates of serious illness, other serious illnesses that put them at greater risk. Many of them are living in multi-generational households, so they're often have children under the age of 5 unvaccinated and older people who are immunocompromised or again, have serious underlying health conditions, and they try to balance safety for everyone in the family. I think when we speak to people and we understand their circumstances, we recognize how fragile the world is for so many people during this time of the pandemic, and how careful many people are being about what they want to do and don't want to do based on that risk-benefit analysis. But we're all in a different place, so we may do that analysis and look at things very differently. In terms of the question about if CDC changes the guidance tomorrow, will we follow immediately? And we can never follow immediately because we have to look at it. I know, with like 100% certainty, because this is how CDC and the state have been operating, they will want local jurisdictions to take a look at what they issue, and they will leave room for local jurisdictions to also think about important metrics to take into consideration. So we're going to need to look at what are the community level metrics they're asking us to evaluate around, and what else needs to get added to that. So I anticipate it will take us a few days. We're very likely, let's say they do release tomorrow, we're very likely to use Tuesday's board meeting as an opportunity to discuss both with the board and the public what we envision, and then we'll spend that week, as we always do, reaching out to our sector partners and our labor partners to hear from them. And then, hopefully by the end of the week, we've got the county's plan. But I think it would be a lot to ask us to move immediately with changes, because we do know that CDC is going to ask everyone to look at local conditions as they make moves. But I am looking forward, of course, to seeing the plan. And I think, again, post-surge, it's helpful to be able to look at all we've learned and then map forward a new road. Of course, based on what we've learned and based on the knowledge that we're going to have to be flexible moving into the future. What we'll also try to do, of course, is at the same time look at what the state has laid out for us about opportunities to be well prepared and incorporate that into the work that we think we need to do in the months ahead. And in terms of are we going to align with the state when they release their recommendations around school policies, I think in all likelihood, we want to, we certainly anticipate doing it. But we have to look at what the state lays out. The state is another place that often asks local jurisdictions to look at local conditions. In this case, we also have school districts that obviously have boards and may move, again, in a direction that may be different from the state. As always, they can be more restrictive than the state or the county, and we welcome that. We welcome school districts moving in a direction that's best for their school community. But I do anticipate, I'm really looking forward to hearing from the state on Monday. I think we'll have a lot more clarity on Monday about what the plan is for schools. And then, as always, our intent is to align as closely as possible. Well, hopefully I got to all your questions, Ron. Thank you.
That brings us to the end of our question period. For any closing remarks?
No, thanks a lot. Sorry. My voice is a little hoarse today. I apologize. I think it's allergies. I'm sure it's nothing else, but hopefully you were able to understand enough. And if we didn't get to your question, as always, please send it in, and we'll talk to you again next week. Thanks a lot, everyone.
Monica, can you hear me?
Yes, I can hear you.
Is your camera icon showing up yet?
I think so, yeah. Yeah,
There
now
we
it's-
go. Excellent. All right. Good afternoon, everyone. Thank you so much for joining us for the Spanish portion of today's briefing. We have Monica presenting. Monica, I have your slides ready to go. So when you're ready.
Thank you so much, Kim. Muy buenas tardes, bienvenidos a la sesión informativa de hoy. Compartiremos nuestros últimos datos del estado del COVID y responderemos algunas preguntas. La doctora Ferrer ya respondió las preguntas. Aquí vamos a incluir la siguiente información. Compartiremos nuestras medidas actuales sobre casos, hospitalizaciones y muertes, incluidos los datos que muestran el impacto de la pobreza en estos resultados. Hablaremos de la información más reciente sobre las variantes que circulan en el condado de Los Ángeles. Presentaremos datos actualizados de cobertura de vacunación, incluidas las brechas de la cobertura entre los niños de 5 a 11 años, y daremos nuevos números que se ven en las escuelas. Informaremos sobre los requisitos de uso de mascarilla, la política provisional de uso de cubrebocas en interiores, y repasaremos la revisión planificada por parte del Estado de las estrategias de mitigación en las escuelas. Terminaremos con algunos comentarios sobre nuestro progreso hacia el contagio moderado y mencionaremos brevemente los lineamientos del Estado y los cambios esperados en la guía entregada por los CDC. Entonces comenzamos. First slide, please. Desde que anunciamos que estábamos llegando al final del devastador aumento invernal, nuestra situación ha seguido mejorando, con caídas sostenidas en muchas de nuestras medidas. Todavía se necesita algo de trabajo para reducir aún más el riesgo en los lugares donde trabajamos y nos reunimos, así como para disminuir aún más las muertes relacionadas con COVID-19, que siguen siendo elevadas. Sin embargo, nuestros esfuerzos colectivos para que las personas se vacunen, reciban el refuerzo, usen la mascarilla y adopten otras medidas de seguridad nos están acercando a estos objetivos. A medida que avanzamos, continuaremos utilizando las herramientas más efectivas para prevenir el COVID-19, y a medida que sigamos viendo mejoras relacionadas con un menor contagio, consideraremos cambios sensibles en nuestras estrategias de mitigación. Antes de echar un vistazo a los números, queremos señalar que a partir de este domingo 27 de febrero ya no informaremos las cifras de COVID los domingos. Cuando publiquemos los lunes el reporte, daremos los números del domingo, además de las del lunes. Durante la última semana, volvieron a disminuir los casos y las tasas de casos positivos con base en las pruebas. Hoy estamos reportando 1.985 nuevos casos. El número promedio de casos nuevos diarios de los últimos 7 días ha disminuido en cerca de 2.400, de casi 3.800 casos durante los 7 días anteriores. Y aunque todavía tenemos una alta tasa de contagio comunitario, nuestra tasa de casos diarios promedio de 7 días ha disminuido a 24 casos nuevos por cada 100,000 residentes. La tasa de casos positivos con base en la prueba diaria promedio de 7 días ha disminuido a 2,2%, lo que significa que 1 de cada 50 resultados de la prueba fueron positivos, en comparación con alrededor de 4 casos que veíamos al principio, de mayor en la misma proporción. Cabe destacar que los recuentos de casos de esta semana reflejan retrasos en los informes debido al fin de semana, al feriado, ya que un laboratorio envió los resultados tan solo la semana pasada. Además, las hospitalizaciones han continuado bajando y hoy reportamos un 33% menos de hospitalizaciones que el jueves pasado, es decir, 1.150 personas actualmente en los hospitales con COVID. Nuestras muertes siguen siendo elevadas, pero en las últimas semanas ha habido ligeras caídas en el número promedio de decesos diarios reportados. Durante los últimos 7 días se reportaron un promedio de 54 muertes diarias frente al informe de un promedio de 67 fallecimientos ocurrido durante los anteriores 7 días. Somos conscientes del trágico costo que tiene cada muerte por COVID y enviamos nuestro consuelo y sentido pésame a todos los que han perdido a un colega, un amigo o familiar a causa de este virus. Next slide, please. La línea de tendencia de esta diapositiva muestra el promedio de casos, hospitalizaciones y muertes desde el 1 de julio de 2020 hasta hoy. Muestra los aumentos drásticos en los casos de Omicron durante la oleada de invierno, así como las fuertes disminuciones que hemos visto en las últimas semanas, aunque nuestro promedio de casos diarios de 7 días, que se muestra con la línea verde, aún no ha bajado a los niveles previos al aumento repentino, ha disminuido en un 94% desde el máximo de un promedio de más de 40,000 reportados el 15 de enero. Las hospitalizaciones en amarillo y las muertes en azul también aumentaron considerablemente durante la oleada invernal, pero no tan rápido, probablemente debido al impacto de las vacunas, que son altamente efectivas para prevenir enfermedades graves y muertes, así como cierta disponibilidad de tratamientos médicos efectivos. Ayer, el promedio de 7 días de nuevas admisiones hospitalarias se redujo a 140. Si la propagación comunitaria sigue bajando y mejora el acceso a tratamientos efectivos, esperamos que las muertes disminuyan más. Next slide, please. Estos gráficos muestran promedios diarios de casos por 7 días, porcentaje de casos positivos y hospitalizaciones antes del oleaje invernal, el punto más alto del pico y el panorama actual. Como puede ver, en las últimas semanas se ha avanzado mucho en la desaceleración del contagio y la prevención de las hospitalizaciones. Salimos del devastador aumento invernal con disminuciones significativas en los casos, la positividad de las pruebas y las hospitalizaciones. De hecho, ahora nos estamos acercando a los niveles previos del aumento. A medida que este progreso nos da un respiro, seremos conscientes de los factores que podrían impedir nuestra capacidad para alcanzar niveles más bajos de riesgo, incluidos aumentos en la propagación comunitaria asociados con la disminución de las protecciones de seguridad, la desaceleración del ritmo de vacunación y la posibilidad de que surja una nueva variante que evada las protecciones de las vacunas. Dado que el virus es impredecible, siempre debemos estar preparados y ser capaces de revisar las acciones de respuesta según sea necesario. Next slide, please. Continuamos siguiendo de cerca los desarrollos relacionados con la variante Omicron BA.2, incluidos los hallazgos relacionados con si en comparación con BA.1 puede propagarse más fácilmente de persona a persona, provocar enfermedades más graves o más resistente a tratamientos o vacunas. La Organización Mundial de la Salud dio a conocer recientemente los siguientes hallazgos. La información inicial que se tiene sugiere que BA.2 parece ser un 30% más contagiosa que BA.1, que es la subvariante de Omicron más común. Aunque se ha documentado la reinfección con BA.2 después de la infección con BA.1, los datos iniciales sugieren que esto es relativamente raro y que la infección con BA.1 brinda una fuerte protección contra la reinfección de BA.2, al menos durante el periodo limitado en que los datos han estado disponibles. Los datos de Sudáfrica, el Reino Unido y Dinamarca nos mostraron que la gravedad de BA.2 y BA.1 sea diferente. Perdón, no mostraron que la gravedad de estas dos subvariantes sea diferente. Estos descubrimientos contrastan con los datos de un laboratorio de Japón que mostraron unos modelos animales, en modelos animales que su gravedad era mayor. Si bien BA.2 está aumentando en la proporción de todas las secuencias notificadas a nivel mundial, el número total de casos está disminuyendo. Continuamos monitoreando las variantes que circulan en el condado de Los Ángeles y esta diapositiva muestra nuestras últimas variantes secuenciadas. La variante Omicron sigue siendo nuestra variante predominante y representa el 100% de todos los casos con muestras secuenciadas recolectadas en la semana que terminó el 12 de febrero. El linaje BA.1.1, un linaje descendiente de BA.1, fue la principal subvariante de Omicron identificada. BA.2 ha ido aumentando lentamente, pero aún representa una proporción muy pequeña de todos los casos secuenciados. A partir del 12 de febrero, BA.2 representó solo el 67 o el 1,2 de los casos secuenciados de Omicron identificados en el condado de Los Ángeles durante las últimas semanas. Esto es consistente con los hallazgos de que si bien BA.2 se ha convertido en la variante predominante en algunos países, no se está extendiendo rápidamente en los Estados Unidos. Next slide, please. A lo largo de la pandemia, hemos visto que COVID-19 ha impactado de manera desproporcionada a ciertas comunidades y grupos en el condado de Los Ángeles, incluidas las comunidades de color, las áreas con una gran cantidad de trabajadores esenciales y en aquellas áreas o zonas donde hay escasez de recursos. Hoy compartimos datos que muestran la interacción entre la pobreza y los resultados de COVID. Las siguientes 3 diapositivas muestran las tasas de casos ajustadas por edad de 7 días, las de hospitalización y las de mortalidad para personas de 5 años y mayores por estado de vacunación y pobreza. Como puede ver, las diferencias en casos, hospitalizaciones y muertes por COVID-19 están asociadas no solo con el estado de vacunación, sino también con si una persona vive en un área con mayores o menores índices de pobreza, con individuos que viven en zonas con más escasez de recursos y con un riesgo sustancialmente mayor. Si bien este patrón fue más pronunciado entre las personas no vacunadas, también hubo disparidades alarmantes entre las personas vacunadas. Por ejemplo, en comunidades donde el 30% o más de las personas viven en la pobreza, la tasa de casos de personas no vacunadas fue casi 9 veces mayor que la tasa de casos de personas no vacunadas que viven en comunidades ricas donde menos del 10% de las personas viven en la pobreza. Las tasas de casos, tanto de las personas vacunadas como de las vacunadas y con refuerzo, también fueron sustancialmente más altas en las áreas con mayor pobreza que en las áreas con menor pobreza. De hecho, las personas no vacunadas que vivían en comunidades ricas tenían una tasa de infección similar en comparación con los residentes totalmente vacunados y con refuerzo que vivían en comunidades de alta pobreza. Next slide, please. Esta diapositiva muestra las tasas de hospitalización ajustadas por edad, por estado de vacunación y pobreza del área para personas de 5 años y más del 5 al 11 de febrero. Independiente del estado de vacunación, vivir en un área con más pobreza estuvo unido a un riesgo sustancialmente mayor de hospitalización y en este caso, cuanto mayor sea el nivel de pobreza, mayor será la disparidad. Por ejemplo, las personas totalmente vacunadas y con refuerzo que vivían en comunidades con las tasas más altas de pobreza tenían una probabilidad 2,7 veces mayor de ser hospitalizadas que aquellas que vivían en las zonas con las tasas más bajas de pobreza. Además, las personas no vacunadas que vivían en las áreas más ricas tenían menos probabilidades de ser hospitalizadas que las personas completamente vacunadas que vivían en las que tienen mucha pobreza. Next slide, please. Por último, esta diapositiva muestra las tasas de mortalidad ajustadas por edad según el estado de vacunación y la pobreza del área para personas de 5 años en adelante del 29 de enero al 4 de febrero. Nuevamente, independiente del estado de vacunación, las personas que vivían en las áreas con más pobreza tenían un riesgo sustancialmente mayor, en este caso, de morir por COVID-19. Al igual que en el caso de las hospitalizaciones, a mayor nivel de pobreza se observaron mayores brechas. Por ejemplo, entre las personas no vacunadas, en las zonas más ricas, la tasa de mortalidad ajustada por edad fue de 8 por 100,000. Al igual que en el caso de las hospitalizaciones, a mayor nivel de pobreza, más brechas. Por ejemplo, entre las personas no vacunadas, la tasa de mortalidad ajustada por edad aumentó constantemente a medida que subía la pobreza. La tasa de mortalidad ajustada por edad fue de 8 por 100,000 en nuestras comunidades más ricas, subió a 25 por 100,000 en las zonas con 10% a alrededor del 20% de pobreza en el área. Aumentó a 53 por 100,000 en comunidades con 20% a casi el 30% en área de pobreza y saltó a una tasa preocupante de 76 por 100,000 para nuestras comunidades más pobres, donde el 30% o más de los residentes viven en la pobreza. Para nuestra sorpresa, los que estaban completamente vacunados y quienes habían recibido las dosis requeridas y el refuerzo y que vivían en comunidades con las tasas más altas de pobreza tenían 3 veces más probabilidades de morir por COVID que los que vivían en las comunidades más ricas, y subrayando las marcadas disparidades entre las comunidades más ricas y las que tienen un alto nivel de pobreza, vemos aquí que un individuo no vacunado que vivía en las áreas más ricas tenía menos riesgo de morir debido a COVID que una persona completamente vacunada que vivía en las comunidades con altos niveles de pobreza. Estos datos sobre casos, hospitalizaciones y muertes son alarmantes, ya que muestran el impacto significativo que la falta de recursos puede tener en los resultados del COVID. Las desigualdades fueron más pronunciadas entre aquellos que no estaban vacunados, pero también afectaron a los individuos vacunados y con refuerzo. Entonces, a pesar de la fuerte protección que ofrecen o que brindan las vacunas, vacunarse por sí solo no es suficiente para las personas que viven en áreas con altos índices de pobreza. El lugar donde la gente vive y trabaja claramente tiene un tremendo impacto en su riesgo de exposición y la disponibilidad de recursos para mejorar la salud. Necesitamos seguir comprometidos a resolver los problemas complejos y de larga data que explican estas preocupantes inequidades y asegurarnos de inmediato de que nuestras acciones posteriores a la oleada no amplíen las brechas al no dar recursos y protecciones adicionales a quienes corren el mayor riesgo de adquirir COVID-19, ser hospitalizados o morir. Next slide, please. Si bien ciertamente no son perfectas y no son suficientes, como acabamos de ver, las vacunas siguen siendo una de las herramientas más poderosas que tenemos contra el COVID-19, y dada su importancia, una vez más reportamos las tasas de vacunación. Desde el comienzo del año hemos logrado un progreso gradual en la inoculación de nuestros residentes del condado de Los Ángeles. Entre el 6 de enero y el 20 de febrero, el porcentaje de individuos de 5 años en adelante que recibieron todas las dosis aumentó del 71 al 74% y el porcentaje de personas de 12 años en adelante que lo hicieron subió del 77 al 79%. Sin embargo, nuestro ritmo de vacunación se ha desacelerado mucho. Y si bien esto es de esperar, dado que 8 millones de residentes del condado han sido vacunados, todavía hay cerca de 1,7 millones de personas que pueden recibir la vacuna que aún no ha recibido su primera dosis, así como alrededor de 2,7 millones de inoculados que aún no han recibido la dosis adicional o la de refuerzo. La cobertura de vacunación para niños de 5 a 11 años sigue siendo baja, con solo el 28% de los menores en este rango de edad completamente vacunados al 20 de febrero. Sabemos que nuestras bajas tasas ponen en riesgo a nuestros niños de 5 a 11 años y a nuestras comunidades, ya que estos pequeños pueden enfermarse. Y sin saberlo, infectar a familiares, amigos, y estudiantes, maestros y otros. Para mantenernos en nuestro camino hacia el contagio más bajo y evitar la aparición de variantes preocupantes, necesitamos vacunar y aplicar el refuerzo a un número sustancial alto de residentes. Next slide, please. Y para aumentar la cobertura de vacunación debemos reconocer y alinear los recursos para ir acabando con las disparidades en la cobertura de vacunación que contribuyen a diferentes consecuencias del COVID. Esto incluye las diferencias que se basan en el lugar de residencia o la raza y etnia, como se ven en las siguientes dos diapositivas, las cuales detallan las tasas de cobertura entre los niños de 5 a 11 años. Cada mapa muestra la cobertura de vacunación para una o más dosis de la vacuna COVID-19 para niños de 5 a 11 años, para cada uno de nuestros distritos de salud, para un grupo racial y étnico diferente. El sombreado amarillo denota distritos de salud con cobertura de vacunación inferior al 22%. El verde indica una cobertura del 22 al 31%. El azul indica una cobertura del 32 a 54% y el sombreado púrpura indica que hay una cobertura de vacunación superior al 54%. El primer mapa muestra los niveles de cobertura para niños asiáticos entre 5 y 11 años. Debido a que este grupo tuvo la mayor cobertura de vacunación, sirve como grupo de comparación. Los otros mapas muestran la cobertura por distrito de salud para niños de color y afroamericanos, latinos y blancos del mismo rango de edad mencionado. Como puede ver en estos tres mapas, se necesitan esfuerzos para mejorar la cobertura entre niños de 5 a 11 años para todos los grupos raciales y étnicos, pero particularmente para niños de color y afroamericanos y latinos. Las tasas de vacunación para estos grupos son bajas en todo el condado, particularmente en los distritos de salud ubicados en las áreas del sur de Los Ángeles, en la parte central del sur de la ciudad de Los Ángeles, áreas de los valles de San Gabriel y San Fernando y todo el valle de Antílope. Next slide, please. Esta diapositiva muestra los niveles de cobertura de vacunación para niños blancos de 5 a 11 años por distrito de salud en comparación con las tasas de niños asiáticos que se muestran nuevamente en el primer mapa. Para ver que en muchos distritos las tasas de vacunación de los niños blancos fueron más bajas que las tasas de los niños asiáticos, pero más altas que las tasas de los niños de color y afroamericanos y latinos. Las tasas de niños blancos fueron más altas en algunos distritos de salud en el sur y sureste de Los Ángeles y las más bajas en el Valle de Antílope. Como se mencionó, estos mapas muestran las brechas en la aplicación de las dosis según la raza y origen étnico y área geográfica. En general, al 20 de febrero, al 20 de febrero, el 58% de los niños asiáticos de 5 a 11 años habían recibido al menos una dosis, frente al 40% de los niños blancos. el 21% de los latinos y el 20% de los de color y afroamericanos en este rango de edad. Estas diferencias continúan señalando la necesidad de hacer frente a las políticas y acciones que no responden a las necesidades de las personas, lo que puede contribuir a que ellas duden al confiar en las vacunas. Estamos trabajando con los aliados para generar confianza en las vacunas y aumentar su aceptación entre las comunidades para generar confianza en las vacunas y aumentar su aceptación entre las comunidades donde muchas personas no se han vacunado. Las vacunas están disponibles sin costo alguno en más de 1.500 sitios a través de equipos móviles y en todo el condado, incluidas las áreas de baja cobertura. También estamos trabajando con aliados confiables para aumentar la concientización, responder preguntas y mejorar el acceso a los puestos de vacunación en las comunidades más afectadas. Las estrategias incluyen ir de puerta en puerta en las áreas aledañas a los sitios de vacunación, tener presencia en los lugares de vacunación, en las escuelas y eventos comunitarios, llevar a cabo actividades de divulgación para los padres en las escuelas, ofrecer a los planteles que den acceso a puestos de vacunación, proporcionar información y recordatorios a través de llamadas telefónicas y mensajes de texto y conectarse vía redes sociales con los residentes locales. Next slide, please. Las escuelas siguen siendo aliados vitales en nuestro esfuerzo para prevenir y controlar el COVID-19 y las pruebas de rutina y de respuesta siguen siendo elementos importantes de nuestra estrategia en las escuelas. El volumen de pruebas en las últimas semanas ha disminuido ligeramente porque el Distrito Escolar Unificado de Los Ángeles y otras escuelas han hecho bien al excluir a los estudiantes que recientemente dieron positivo por COVID del programa de pruebas de rutina. Datos muestran que entre el 14 y el 18 de febrero se administraron casi 460,000 pruebas con una tasa de casos positivos del 0,80% frente al 14% a principios de año. Es probable que esta fuerte disminución refleja las tasas más bajas de contagio comunitario, así como el impacto de las estrategias de mitigación que se mantienen en las escuelas para proteger a los estudiantes, maestros y al personal. Next slide, please. Esta diapositiva muestra la cantidad de casos de COVID-19 entre los estudiantes y el personal de las escuelas de transición a grado 12 desde el comienzo del año escolar hasta el 20 de febrero por nivel de grado. Como puede ver, durante la mayor parte del año escolar, los casos de estudiantes y personal se mantuvieron muy bajos, pero aumentaron rápidamente a partir de finales del 2021 y principios del 2022 y después disminuyeron drásticamente. Durante y después del pico, la mayor cantidad de casos han sido de estudiantes de escuela primaria que se muestran con la línea amarilla sólida, seguidos de estudiantes de secundaria que están en la línea azul y luego estudiantes de preparatoria en verde sólido. Los deportes juveniles, la línea roja sólida, representaron la menor cantidad de casos entre estudiantes, pero para cada uno de estos entornos los casos de estudiantes están disminuyendo rápidamente. Nuestros datos más recientes muestran que en solo una semana los casos disminuyeron en un 65% entre estudiantes de primaria, un 61% entre los de secundaria y un 64% en alumnos de preparatoria. Hay menos casos de COVID-19 entre el personal que entre los estudiantes, como lo muestran las líneas punteadas. Los casos del personal han disminuido y los recuentos ahora son como los que se vieron antes de nuestro aumento invernal. Es de destacar que, al igual que en el caso de los estudiantes, la mayor cantidad de casos del personal se produjo en las escuelas privadas, en las escuelas primarias, luego en las secundarias, después en las preparatorias y finalmente en los deportes juveniles. Next slide, please. Salud Pública está investigando 38 brotes escolares activos por debajo de los 46 que estaban bajo investigación la semana pasada y los 56 de la semana antepasada. Los brotes de esta semana incluyen 13 nuevos que se desataron entre el 13 y el 19 de febrero, 7 en escuelas primarias, 3 en secundarias y 3 en deportes juveniles. Cuando se combina con nuestra baja tasa de positividad en las escuelas y la disminución de casos entre los estudiantes y el personal en las más de 3.100 escuelas en el condado de Los Ángeles, la cantidad relativamente baja de brotes sugiere que las estrategias de las escuelas, como las pruebas de detección y de respuesta, el aislamiento y la cuarentena y las pautas para el control de infecciones, continúan ayudando a mantener el bajo contagio en las escuelas. A su vez, ayuda a mantener a nuestros estudiantes, maestros y personal seguros y asistiendo al salón de clases. Next slide, please. En esta diapositiva se muestran 77 brotes en escuelas y programas de transición a grado 12 que se desencadenaron desde el 1 de enero hasta el 19 de febrero por tipo de escuela. Como puede ver, la mayoría de los brotes se originaron en las escuelas primarias, seguidas de los deportes juveniles y brotes que ocurrieron los brotes ocurrieron en todo el condado. Next slide, please. Dadas las preocupaciones planteadas por algunos padres sobre el uso de mascarilla en las escuelas y la necesidad de equilibrar los riesgos y los beneficios, queremos compartir información que ha sido utilizada por los CDC, el estado y el condado para evaluar las protecciones de seguridad necesarias en las escuelas. Al mismo tiempo, reconocemos que muchos miembros de personal, maestros y padres aún apoyan el uso de tapabocas en las escuelas. Un estudio de la Universidad Johns Hopkins y que incluyó a 2,1 millones de personas el año pasado, mostró un aumento del 38% en el riesgo de enfermedades relacionadas con el COVID en los hogares cuando un niño asiste a la escuela en persona. Sin embargo, a medida que aumentó el uso de capas de protección en los planteles de 7 o más capas, incluidas los mandatos de uso de mascarilla para estudiantes, el mayor riesgo desapareció por completo. Esto sugiere que los requisitos de uso de mascarilla, junto con múltiples acciones protectoras adicionales, pueden mantener a las familias, los hermanos no vacunados y los miembros de la familia de alto riesgo a salvo del contagio de COVID-19. Otro estudio de investigadores de la Universidad de Duke analizó datos de más de 1 millón de estudiantes y miembros del personal de kinder a grado 12 en Carolina del Norte durante casi un año de vigencia de los requisitos de uso de mascarilla desde agosto del 2020 hasta julio de 2021. Descubrieron que el contagio en la escuela durante el otoño, los meses de invierno y verano permanecieron tan bajos como el 1%, incluso cuando estaba aumentando entre las comunidades. El uso de cubrebocas en las escuelas se identificó como el común denominador para mantener la baja propagación en todos estos periodos. Un estudio de los CDC en las escuelas de Arizona en octubre de 2021 mostró que los brotes de COVID-19 eran mucho más comunes en los planteles que no tenían el requisito de uso de tapabocas en comparación con las escuelas que los tenían. Como se mencionó, existe un sólido apoyo entre los padres para el uso de mascarillas en entornos escolares. Según una nueva encuesta pública del noticiero CBS y la organización YouGov, la mayoría o el 57% de los padres de niños con niños en edad escolar apoyan los requisitos de mascarillas en los planteles en comparación con el 36% que afirmó que las mascarillas deberían ser opcionales y el 7% que dijo que no se debería permitir el uso de mascarillas. De manera similar, en una encuesta realizada por la Universidad de California, Berkeley, copatrocinada por el periódico Los Angeles Times, el 61% de los padres en California apoyaron continuar este año escolar con el uso de mascarillas en los centros educativos. En este momento, el Estado continúa exigiendo el uso de mascarilla en interiores, en las escuelas, independiente del estado de vacunación, como parte de un programa integral de seguridad escolar. Sin embargo, el Estado está reevaluando las estrategias de mitigación, incluido el uso de mascarilla, a la luz de los números de casos actuales y las tasas de positividad de las pruebas de hospitalización y de vacunación para niños en edad escolar, así como las tendencias nacionales e internacionales. El Estado planea anunciar las consideraciones y los plazos el 28 de febrero. El Estado nos proporcionará un marco para mitigar la propagación en las escuelas con el que probablemente nos alinearemos, pero según lo recomendado por el Estado, consideraremos las medidas de nuestro condado o los números de nuestro condado junto con las necesidades y prioridades locales al determinar qué partes de dicho marco aplicaremos en el condado. Next slide, please. Pudimos permanecer abiertos durante la dañina oleada invernal porque usamos un amplio conjunto de medidas de protección que ayudaron a disminuir el impacto de Omicron. Si bien nos sentimos aliviados de haber reducido significativamente el estrés en nuestro sistema de atención médica, lo que llevó a los cambios que se introdujeron esta semana en las órdenes de los oficiales de salud del condado, aún queda trabajo por hacer para cerrar las brechas en los resultados por geografía y raza y etnia, ya que esta desproporción continúa causando interrupciones considerables, enfermedades y muertes para muchos en el condado. Por lo tanto, al avanzar durante el periodo posterior a la oleada, todavía hay entornos y situaciones en las que sigue siendo apropiado utilizar las poderosas herramientas disponibles que impiden la propagación del virus. Permítanos revisar rápidamente las modificaciones a nuestra orden del oficial de salud que permite que a partir de mañana los establecimientos comerciales, empresas y lugares para eventos que verifican el estado de vacunación permitan que las mascarillas sean opcionales para las personas vacunadas con todas las dosis. Los establecimientos comerciales, empresas y lugares para eventos tienen dos opciones para eliminar los requisitos de uso de cubrebocas para las personas con todas las vacunas. Opción 1. A partir de este viernes, los establecimientos comerciales, empresas y lugares para eventos que deseen permitir que los clientes y trabajadores con todas las vacunas no usen mientras están en el interior, deben verificar que el 100% de los clientes y visitantes mayores de 5 años y trabajadores antes o al ingresar de los espacios interiores que estén vacunados. Muestren su tarjeta de vacunación que indique que ha recibido las dosis o si no está completamente vacunado, proporcione un resultado negativo de la prueba que se haya hecho recientemente. Las pruebas para los clientes deben realizarse dentro de los 2 días anteriores a la entrada si se trata de una prueba de PCR o 1 día antes si se trata de una prueba de antígeno. Los empleados podrán presentar un resultado negativo de la prueba cada 3 días. Aquellos que no estén completamente vacunados o no muestren el comprobante de vacunación deben proporcionar una prueba o el resultado de una prueba negativa y continuar usando la mascarilla bien ajustada mientras están en los interiores, según lo exige el Estado, excepto cuando comen o beben activamente. Opción 2. A partir de este viernes, los establecimientos comerciales, empresas y lugares para eventos que deseen permitir que sus clientes con todas las vacunas se quiten el cubrebocas en el interior mientras todos los trabajadores en el sitio permanecen con cubrebocas deben verificar que el 100% de los clientes de 5 años en adelante, antes o al momento de ingresar a los espacios interiores, proporcionen el comprobante de vacunación completa o muestren el resultado negativo reciente de una prueba viral de COVID-19. Las pruebas para los clientes deben haberse realizado dentro de los 2 días anteriores a la entrada si se trata de una prueba de PCR o un día antes si se trata de una prueba de antígeno. Como recordatorio, los clientes con todas las vacunas pueden quitarse la mascarilla en el entorno interior, mientras que los clientes que no están completamente vacunados deben seguir usando la mascarilla bien ajustada mientras están en el interior, según lo exige el Estado, excepto cuando comen o beben activamente. Hay varias cosas importantes en estos cambios. Las empresas y otros establecimientos no están obligados a implementar estas opciones. Si lo prefieren, pueden seguir exigiendo el uso de mascarilla en interiores para todos los clientes y empleados. Dado que es probable que solo estemos un poco lejos de eliminar los requisitos de uso de mascarilla en interiores en todo el condado, debido a la rápida disminución de las tasas de casos, aquellos lugares que aún no han establecido sistemas para verificar las vacunas o las pruebas negativas, pueda que quieran retrasar la construcción de costosos sistemas de verificación y en su lugar continuar con los requisitos de uso de cubrebocas en interiores hasta que el condado levante estos mandatos sin necesidad de hacer verificaciones. Como hemos señalado en el pasado, esos cambios en la orden del oficial de salud no se aplican en entornos donde las reglas estatales o federales requieren que se usen tapabocas en interiores, independiente del estado de vacunación, como escuelas, guarderías, entornos juveniles, centros de atención médica, correccionales, refugios para personas sin hogar y de emergencia, centros de enfriamiento, cuando se viaja en transporte público y en terminales de transporte. También continuamos recomendando el uso de mascarilla cuando están en interiores, especialmente para aquellos que son particularmente vulnerables al COVID y quienes viven con personas vulnerables. Los cubrebocas brindan una fuerte protección a la persona que los usa, así como a quienes los rodean. Y es una de las cosas más fáciles que podemos hacer para prevenir la propagación del COVID-19. Esto significa que incluso en sitios que requieren vacunación y verificación de pruebas, cualquier persona que muestre el comprobante de vacunación completa antes de ingresar aún puede optar por usar la mascarilla en el interior. Para garantizar que los trabajadores tengan suficiente protección en sus lugares de labor, hemos mejorado el requisito de que los empleadores proporcionen mascarilla y los empleadores ahora deben ofrecer sin costo alguno al empleado cubrebocas de alto grado, como los N95, KN95 o N94. Hemos publicado un detallado conjunto de herramientas en nuestro sitio de internet sobre cómo cumplir con la orden modificada del oficial de salud y alentamos a las empresas o las invitamos también a los trabajadores a echar un vistazo y contactarnos con sus preguntas. Next slide, please. Como se indicó, se requerirá el uso de mascarilla en entornos interiores hasta que estemos en o por debajo de la propagación moderada durante 7 días consecutivos, excepto cuando lo exijan las reglamentaciones estatales o federales o en establecimiento que se adhieran a nuestra política provisional de uso de tapabocas en interiores. Nuestra política actual de uso de cubrebocas se alinea con la guía actual de los CDC, que recomienda el uso de mascarilla en interiores en áreas de contagio sustancial y alto. Anticipamos un cambio en la guía de los CDC pronto, momento en el cual consideraremos cómo ajustar nuestros requisitos. Mientras tanto, alcanzar el hito de contagio moderado activará el cambio al requisito de uso de mascarilla. Esta diapositiva muestra nuestro progreso hacia ese hito. La tasa de casos acumulada de 7 días observada durante la semana se muestra en verde y una proyección para la tasa de casos acumulada de 7 días se muestra en la línea discontinua azul. Esta proyección se basa en una tasa de disminución de 5,5%, que es la tasa de disminución entre los recuentos de casos informados acumulados de 7 días, el 16 y el 23 de febrero. Sabemos que las enfermedades no siguen una tasa lineal de reducción y nuestra tasa de disminución puede no ser constante a lo largo del tiempo, por lo que esto es solo un estimado. La línea naranja muestra el umbral de 50 casos por cada 100.000 habitantes, lo que se traduce en un promedio de 7 días de cerca de 730 casos por día. El contagio moderado se define como nuestra tasa de casos acumulada de 7 días cuando cae por debajo de ese umbral. Con base en nuestra tasa actual de descenso, aún anticipamos alcanzar el contagio moderado a mediados de marzo. La mejor oportunidad que tenemos para llegar a esto a tiempo es que cada uno de nosotros haga todo lo posible para continuar con las medidas de seguridad recomendadas, como el uso de mascarilla, hacerse la prueba y la vacunación. Next slide, please. A lo largo de la pandemia, al desarrollar nuestras estrategias de mitigación, hemos considerado cuidadosamente la orientación basada en lo que han encontrado los científicos de la CDC y el Estado. Los marcos federales estatales reconocieron la necesidad de considerar también las condiciones locales antes de finalizar los planes de acción en una jurisdicción determinada. Cuando esta guía abordó adecuadamente las condiciones locales y apoyó nuestras prioridades, generalmente alineamos nuestras políticas y estrategias con esas recomendaciones federales y estatales. Mañana mismo esperamos que los CDC publiquen un marco actualizado para gestionar el COVID-19 que revisaremos detenidamente para evaluar en qué nos alinearemos. Si bien los CDC aún no han publicado este plan, se compartió cierta información sobre los elementos clave del marco actualizado con las jurisdicciones de salud locales. Sobre la base de esta información, esperamos que el marco se centre en los siguientes 3 objetivos: prevenir enfermedades graves, minimizar la carga sobre el sistema de atención médica y proteger a los más vulnerables. También anticipamos que el marco incluirá medidas actualizadas que respaldan los objetivos generales y se pueden usar para monitorear el progreso y ayudar a guiar las estrategias políticas y decisiones locales. Por ejemplo, las medidas pueden estar relacionadas con cobertura de vacunación, indicadores comunitarios definidos por los CDC y datos locales como variantes circulantes de preocupación, números en entornos de congregación de alto riesgo y resultados de la vigilancia de aguas residuales. También esperamos que el marco brinde recomendaciones a las jurisdicciones de salud locales y aliados para poner en marcha acciones e intervenciones en las comunidades con un enfoque potencial en actividades de vacunación como promoción, divulgación y distribución de vacunas, medidas de prevención, incluidos comportamientos de prevención individuales y estrategias comunitarias como pruebas, uso de mascarilla y otros enfoques. Cuando los CDC publiquen este marco, revisaremos cuidadosamente las metas, los números, las estrategias propuestas con relación a las condiciones y prioridades locales. Determinaremos cómo alinear esto con nuestro marco y enfoque e integraremos las medidas y estrategias relevantes en nuestros planes de mitigación. Finalmente, Para guiar la planificación futura y posterior a la oleada, el Estado también ha publicado un marco actualizado titulado El Plan Más Inteligente de California, la siguiente fase de respuesta al COVID. Este plan traslada el enfoque a la preparación para la próxima etapa de COVID-19 que puede incluir futuras oleadas y nuevas variantes. Los componentes principales son vacunas, mascarillas, estar alertas, prepararse, pruebas, educación, medicamentos que se refieren al acceso a los tratamientos disponibles. El plan también propone un conjunto de medidas de preparación y pretende garantizar que se cuente con los recursos y las capacidades adecuadas. Mientras nos preparamos para la próxima fase de COVID-19, continuaremos considerando la orientación estatal y federal. Y junto con las condiciones y prioridades para garantizar que nuestra estrategia brinde al condado de Los Ángeles la mejor protección contra el COVID. Esto es todo por hoy. Muchas gracias y nos vemos en la próxima sesión.
Thank you so much, Monica, and thank you to everyone who joined us today. As a reminder, if you have questions for us from the media, you can send them to our inbox at media@ph.lacounty.gov. Thank you once again, and we will see you next week.